Well, look, I think the recent New England Journal paper that you and I have talked about is very interesting, comparing Lexapro to psilocybin. I wrote about it recently, and my little diatribe basically said I think the paper was in some ways misinterpreted. It was positioned as a negative trial, though I saw it as anything but a negative trial. Maybe just for background.
Could we zoom out just for a second and give people an overview of the objective or the hypothesis of the study?
Yeah, the question that was being tested was, is an intermittent dose of pure synthetic psilocybin more effective, I think is the way the question was posed, than the top tier SSRI for patients with depression.
Yeah.
So Lexapro is a relatively new SSRI, very well tolerated.
Citalopram?
Yeah. Mm-hmm. It does have sexual side effects. That's its most common side effect.
That's true of other SSRIs.
Absolutely,
as well.
yeah. SSRIs are known for having sexual side effects. Some of them also come with, incredible amounts of somnolence, incredible amounts of weight gain.
Somnolence, sleepiness.
Sleepiness, yeah. Lexapro seems to be relatively free of that for most people, which is why it's kind of more of a go-to drug. Comes in 2 doses, 10 and 20 milligrams. Generally, most people need 20 if they're going to go to it, but you usually start people at 10, go to 20.
And this is a daily...
It's a daily drug. Yep. So, the participants are divided into 2 groups. One group is given Lexapro. Let me think. I believe that they all started out at 10 milligrams for 3 weeks and then were increased to 20 milligrams for 3 weeks, or maybe it was 4 plus 4. I can't remember. It was a relatively short study. In the psilocybin group, the participants were by the way, it's an aside, they were also given 1 milligram of psilocybin, which is an important point I should make.
And if that word is unfamiliar to folks, so psilocybin is a molecule found in psilocybe mushrooms, also known as magic mushrooms. These are mushrooms that impart psychedelic effects at a sufficient dose.
We'll come to talk about that dose. So the subjects were all recruited knowing that they would get psilocybin no matter what, because that was an important recruiting tool. People wanted to be in a study where they were going to get the psilocybin, and that has to be taken into account from the standpoint of patient selection. So every trial has to be thoughtful about what type of people it's selecting, and are they representative of the population you're going to want to extrapolate your results to. So I flag this to make the point that when you have a patient population that says, I really, really want to get psilocybin, and you say, okay, well, you're not going to get necessarily the full dose. There's only a 50-50 chance you're going to get the full dose, but you're going to get some. So you're either going to get 1 milligram or 25 milligrams. And we'll put in context what those doses mean in a second.
And just to bracket one thing, so what makes this study and paper worthy of discussion is that it is a head-to-head comparison, with lots of nuance, of course, of psilocybin with, I think, 2 or 3 sessions total in the intervention arm, versus Lexapro, very common SSRI for major depressive disorder.
Yep.
Please continue.
Yeah. So to your point, the group that was in the true psilocybin group received, I think it's just 2 doses spaced out 3 weeks apart of 25 milligrams of psilocybin, which depending on the variant of mushroom. So when you dry a mushroom out, its yield of psilocybin, pure psilocybin, can be as low. I went and reviewed all the lit on this. Can be as low as 1.7%, can be as high by weight, can be as high as, even 4 or 5%. So
incredible variability.
Yeah. So the 25 milligrams was clearly a hallucinogenic dose.
Yep.
So probably in the 4 to 5 gram of mushroom dose. So they used a number of, there's one other point I should explain about research. Generally, when research is done in a credible fashion, you have to call your shot before you do the study.
Pointing to center field.
That's right. You have to be able to not just say, I'm going to hit a home run, I'm going to hit a home run over that wall. And that's called your primary objective. So one of the things that is important to understand when you're evaluating research is, was it pre-registered? So when the study...
Right. Did they call their shot by naming their primary outcome
That's
measure?
Right. And so in the United States, anything that's funded by NIH, for example, has to be pre-registered on clinicaltrials.gov. So I would encourage anybody to go to clinicaltrials.gov and just start perusing. And what you'll see there is a list of all of these ongoing studies. They'll say, started here, and it's a template, so it always looks the same, and it's very easy to navigate these things. Here are the investigators, here's the hypothesis, here's the experimental design, here's the inclusion criteria, the exclusion criteria, here is the primary outcome, here are the secondary outcomes, and it shows you all of that stuff. So you have to pre-register this, you have to state what you're doing. If you don't do that, it becomes very difficult to publish your work in anything prestigious. This, of course, was published in the, hands down, most prestigious medical journal in the world, the New England Journal of Medicine. So they pre-registered around one type of survey, one type of depressive survey. Because unlike, say, giving people drug to treat cholesterol, where you have an objective metric, you can say, well, did it lower ApoB or LDL-C or something like that? Here you're relying on subjective outcomes, because in such a short study, you're clearly not going to be able to follow people for, wait, was there less depression in this, or was there less suicide in this group, or something, like a hard outcome, did people have, fewer absent days from work or something like that. So and it's been a while since I wrote this, the primary survey that they used, I believe, had 9 categories, or maybe it was 12. And the difference between the groups, the Lexapro group and the psilocybin group, was not statistically significant. So both groups achieved an improvement in their depressive scores.
Yeah, I think it was 6 and 4 points respectively.
Correct. And I think it was a 9-point scale.
Something like that.
Yes.
But you pointed out something very important. And I guess we should just step back for a second. So the upshot, and then let's come back to these questions, but the upshot summary of the study was what?
There was no difference between this drug and between psilocybin and this drug. It was positioned as a negative study.
Got it. Meaning I don't want to say failed, because that's just not really how science works, but the intervention did not, meaning, well, psilocybin in this case was not superior to.
That's right. It was
escitalopram. TIE.
That's right.
All right. So this is a topic that is endlessly interesting to me. What we're getting into, which is study design, and really digging into the nuance and how beneficial it is to know how to read a study. And this will seem like maybe just a friendly plug, but I highly recommend people read a series of articles that you published, and they are called, what is it, Studying the Studies, or
Studying Studies.
Studying Studies, to increase your scientific literacy, because we're going to get into some of the weeds, and I think it'll be, I hope it'll be interesting to people.
And the other thing we're doing, if I can plug something, and I don't know when we'll have this out yet, but we're creating a course where about a year ago, we started recording our weekly journal, our monthly journal club. So every month inside our practice, we do journal club, which is just like old school journal club for anybody who's been in a lab. So one person will present a paper. It usually takes an hour to an hour and a half. And we get into a complete dissection of the paper. And we do it in a really kind of methodical way. And the topics vary greatly. So
highly recommend everyone do this. Honestly, witnessing the complete mayhem and confusion over the last year with respect to anything science related, certainly the most obvious of which being anything COVID or vaccine related, has made it so clear to me that this is really, it's hard for me to think of something that is higher priority.
And we just decided to do this. We've been doing journal club inside our practice for years, but it occurred to me a year ago, why aren't we recording this to later package and put out there? Because nobody comes out of the womb knowing how to read science. Like, we just have to accept the fact.
It's completely learned.
It is a totally non-innate thing. Evolution had zero desire to teach us this skill. So you have to learn it. And, some of us were really lucky to be in labs where people were really good mentors, and they beat into you how to do this. And again, the topics that we explore are, the latest on semaglutide, which we'll talk about today, I think, the role of testosterone replacement therapy in men with type 2 diabetes, a huge paper that came out recently, this topic. So it doesn't matter what the subject matter is. The process of thinking is actually quite similar.
The process of thinking, dissecting, and skeptically, but not necessarily cynically looking at the purported outcomes, I think is really important. So coming back to this paper, super prestigious journal, study comes out, psilocybin versus Lexapro, negative study, or negative outcome rather. Then we have this questionnaire, let's just call it, that is determining the results, and the results come back, the differences come back as statistically insignificant. However,
right,
as you pointed out when you wrote about this, that doesn't necessarily mean clinically insignificant, depending.
And nor does it mean that it wasn't. So let's go back and explain what statistical significance is as well, because now there's 3 points. You reminded me of something else that I think is worth stating. How is statistical significance determined, and what does it mean? We hear this term all the time. Statistical significance is basically asking a question: what is the probability that the difference that's observed between these groups is by chance? To answer that question, you have to know a priori how big an effect size you would expect to see between these two groups.
A priori meaning beforehand, you need to know what magnitude of difference you would expect to see between the two groups.
That's right. And that's really important because that determines what's called the power of your study.
Mm-hmm. And that is how you need to, sorry to keep jumping in here, but the part of the importance of determining or speculating or guessing correctly the magnitude of difference, like the difference in effect sizes, because that also will determine how many subjects you need to recruit.
That's right. So there's something called a power table, which I think we include in one of the studying studies articles, which I remember when I got to the lab was one of the first things my PI, principal investigator, showed me. He said, this is going to be one of the most important tables you'll ever pay attention to when you're doing research, because the table has on, it's a complicated table to look at, but on the like horizontal axis, it has effect size of treatment A. On the vertical axis, it has difference between treatment A and treatment B. So this will be like 10%, 15%, 20%, and then here it would be like 5, 10, 15, 20. So for example, treatment A would yield, if you predict it's going to be a 30% effect size versus a 40% effect size, you go to 30 and 10. Does that make sense?
Yep.
You're the baseline plus the delta. And then within each square, you typically have two options at either 80 or 90% power. Obviously, 90% power means an even higher standard, and it requires more sample, like it has a greater sample size. So it's very common in research to underestimate or overestimate your effect size. And if you overestimate the effect size, you can underpower a study. And I think there's actually a pretty sizable chance that that happened here.
Yeah.
Because the power analysis suggested they were looking for a 4-point difference on this scale.
It came back with 2.
It came back with a little over 2.
A little over 2.
Yeah.
Average.
So it's not surprising that it came back not statistically significant, because they had engineered the number of participants to only be statistically significant if there was a difference of 4 points or greater. And so on the one hand, you would say, well, that's really impressive. That was a very high bar. My question is, was it too high a bar? Is 4 points necessary when you're really trying to do a study against the gold standard, right? It would be one thing if you were doing a study against a placebo, where you do want to set a very, very high bar. But this is akin to almost like a phase 3 drug trial, where you're trying to compare a new drug to an existing blockbuster gold standard drug, and simply being non-inferior to it, and maybe even potentially better on some of the secondary metrics as this one was, could be more than enough to advance clinical utilization and promulgate further studies.
Yeah.
So that was one of my first concerns with this study. Was I don't think it was powered correctly, because I do wonder if 4 was too high an expectation against this treatment. Of course, other issues are, was this study long enough, right? This was a relatively short study. Mm-hmm. And it could have gone the other way. It might be that after a year, it flipped, and Lexapro was hands down the winner, and psilocybin's effect waned. We don't know, but again, that's another thing to be concerned with. And then the point that you brought up is, which is a subset of what we were just talking about, is look, maybe a 2.5 point increase is clinically really relevant. And the other point here is,
and I definitely want you to give, if you remember, and it can be rough, but some of the examples of the questions.
That's right. And that's the final point here is not all questions are created equal, right? So some of the questions on that scale are like, are there times when you don't feel good about yourself? Versus, like, there are days I can't get out of bed. Those are not the same question to me. Like, those are very different questions. A person who says, yeah, like, honestly, more than 50% of the time I don't feel good about myself, clearly that's a problem, and clearly that's something you want to address. But that person is probably a lot more functional than the person who says, I can't get out of bed.
Yeah, or I think that, another two examples to compare would be...
Well, one about suicidal thought as well.
Right. Yeah. Or I sleep 10 or fewer hours per day, or 12 or more hours per day, and that might account for, say, a 2-point difference on an individual questionnaire. But then another question, which was something like, I feel badly about myself most of the time versus, or on a daily basis versus, say, less than half the time, or something along those lines.
Yeah.
Then, as you mentioned, questions about that could include suicidal ideation. So not all points are created equal.
Right.
Another thing that, I wondered, because I have, in part helped fund research at Imperial College, where this came out of, and a bunch of other places. And in conversations with a number of different neuroscientists, they said, well, these are people who are very experienced with designing studies and being published. They said, well, there are times when you have to choose between the primary outcome measure you think the establishment, so to speak, is going to most respect, or the primary outcome measure that you think is going to move the most. And this could be a case, and I'm not speaking for Robin or anyone else involved with this study, but this could be an example of picking what the establishment would have wanted to see, and then having the secondary outcome measures move in some very interesting ways that maybe in retrospect could have or should have been the primary outcome measure.
Correct.
If you had more confidence in those to begin with. So it's just...
Do you know what the budget was for this study?
For this study, I don't, but I'm glad you mentioned budget, simply because I think this underscores how important, at least in the US, because I'm involved with Hopkins and UCSF and a number of other places, how important it is to try to open up state and federal funding for this type of research from NIMH, NIH, et cetera, because right now it's easy for someone to say, well, that was stupid. Why didn't they just have 50 people in each arm? And the answer is, it costs a lot of fucking money. And it's hard to raise money in some cases.
Yeah, I mean, look, I think net, this study must be viewed as a very positive finding.
Yeah, I agree.
Because the side effect profile was obviously higher in Lexapro. So again, people taking Lexapro are far more likely to complain of, if they're males, erectile dysfunction, sexual malfunction, reduced libido, things like that. How we wouldn't want to explore this to the nth degree, I don't understand. And of course, there's other things I'd want to explore, like microdosing, right? These were macrodoses. So these were people taking, a full hallucinogenic dose every 3 weeks, I believe. And that's not necessarily an easy thing to do either. So I'd want to understand what that's like versus what would taking a couple of milligrams per day, which would be, well below the threshold of perception, or 3 times a week or something. You hear a lot of anecdotal talk about those things being beneficial to people. I'd like to see that studied. And in some ways, that would be an easier thing to study, because that's the other limitation of this study, which must be noted, which is technically it was not a blinded study.
Yeah,
it was a randomized study, but it wasn't a blinded study. There was no confusion about which group you were in.
This is one of the biggest challenges. I think there are ways to solve for it that I find pretty compelling from a scientific standpoint, but it's very hard to blind when you're using hallucinogenic, much less sort of mystical experience level dosing of a psychedelic. And it raises, as you noted, well, given the frequency of administration, so you have, say, 2 sessions with psilocybin at clearly psychedelic doses. These would be, I would say, in most people, sufficient to produce some type of what you might call mystical experience. And there are questionnaires that Johns Hopkins has developed, Roland Griffiths and Matt Johnson and that team, to measure mystical experience, ego dissolution, sense of unity, etc. But when you look at the results, and we assume for the time being, even though I think people should look really closely at the appendices and the secondary outcome measures, let's say that they're break even. All right, this is a tie. But on one hand, as you said, you have more side effects. You have daily administration. And then on the other hand, you have administration every 3 weeks. And I think that were they to, and they may still plan on doing follow-ups in other university studies, there's quite a bit of durability that's seen with this type of administration of psilocybin, even out to 6, 12 months. It raises some really interesting questions, right? The most obvious of which is, how does this work? Yeah. Because if the SSRIs are on some level, I don't want to say suppressing symptoms, maybe masking tendencies. I don't know the right way to phrase it, but it is a maintenance drug. It's an ongoing administration versus highly intermittent. By what mechanism are these changes taking place, right? Is it just flooding the brain with a compound that has a biochemical effect, or does it relate more to changing the content and narrative and sort of what work can be done in those sessions themselves? Raises a lot of interesting questions.